Hello everybody. So today class is one of our most important classes in this course because today you will get the foundation of auscultation, ECG, GVD, all of this stuff, how to check them, what do they mean, and how we have to deal with them. So this is why I left this page for today. Just a second, sharing my screen. Can you see my screen? Somebody say yes.
Yes.
Excellent. Okay, so back to this screen. You can see, guys, we have here something called the pressure volume loops and the cardiac cycle. So this is super important because here we are going to speak about normal heart physiology. Yes, that's one thing, but it's integration with pathologies, different pathologies, valvular pathologies, different electrical activity of the heart pathology, so many different stuff. This page will consume the most of our days today, but it's one of these pages in the book that if you finish it good, everything else will be much easier. So let's start this. Pressure volume loops and cardiac cycle. So the idea of cardiac cycle goes something like this. We have the systole and we have the diastole. It's two periods of our heart contraction. So it is, we have like the S1 and the S2. Between S1 and S2 we have the systole. Between S2 and S1 we have the diastole. So basically it goes something like this. So between S2 and S1 we have the diastole, S1 to S2 it's the systole. Please know that the systolic period is much shorter than the diastolic period because it just like the systolic period is just the contraction, so it just takes a portion of a second. While the diastole, during the diastole you have a relaxation of your heart, which is the longer amount of period which is required for your heart to accommodate for all of that blood that will be shifted from the atria to the ventriculi. So now I want you guys to know what valves are open and closed during S1 and S2. So during S1, we have systole. So it seems logical that the blood will go outside of the ventricles during systole, well, contraction of the ventricle. So the blood will be going out from the left and right ventricle to the pulmonary trunk and the aorta, and that's systole basically. So if they want to go out, which two valves would need to be open? The two valves that will be open will be the aortic valve and the pulmonic valve. Please keep in mind that the sound itself, the creation of the sound, it's not due to the opening of the valve, but it's due to the closure of the other valves. So which two valves close during systole? These will be the atrioventricular valves, which are the mitral and the tricuspid. So why does the mitral and the tricuspid close? Well, they shut down, so there will be, when the contraction will happen to the left ventricle and the right ventricle, when the contraction will happen, the blood will not regurgitate back through the mitral valve. So the mitral valve just shuts down during the systole. So, okay, the sound that is created by S1 is due to mitral valve and tricuspid valve closure. And the sound created by the S2 is due to closure of the aortic and the pulmonic valve, which they must close. Why? Because at that moment, the mitral and the tricuspid open, and when the mitral and the tricuspid open, they allow the movement of the blood from the atria to the ventriculi to fill the heart, to enter again the cardiac cycle, and to contract again, and this is just a cycle. It keeps going. Okay, so first of all, we have the following. We have, I want you to know your normal blood pressure. When you check your blood pressure, norm, they always told us it's 120/80. What does that mean? It's systolic blood pressure divided by diastolic blood pressure. So, 120/80. So, who controls mainly the systolic blood pressure? That will be your heart. Who controls mainly your diastolic blood pressure? That will be mainly your vessels. To be more exact, is it the capillaries or the arterioles? It's the arterioles. Don't make the mistake of saying the capillaries. Remember, before on the arterioles, there is something called the precapillary sphincter that controls your diastolic blood pressure and keeps it in place. Okay, so we have the following now. S1 has just occurred. So what does it mean, S1? We said it's a closure of the mitral and the tricuspid valve. But the pressure volume curve for this exact chamber, it's only the left ventricle. So don't confuse it with so many other stuff. It's just the left ventricle. We are not speaking about the right ventricle, not the left atrium, not the right atrium. It's just the left ventricle. So to make it simple, this is all here is speaking about the left ventricle. The same with this graph. Only the left ventricle, and that's what you have to know. So during S1, we have the mitral valve closure. So when the mitral valve closes, you can think what will happen. Mitral valve is closed. What about aortic? Well, it's still closed. Wait, so you mean all of the valves of the heart are closed? Exactly. So during the initial contraction, when you hear the sound of S1, all of the valves inside of your heart, all 4 valves are closed. What does that mean? It means that nothing will come in, nothing will go out. We call that isovolumetric, which means iso means the same. Volumetric, it means like volume. So it's isovolumetric contraction. It means that the volume will not change. If the volume will not change, that means all of the valves must be closed. So from S1, when it happens, mitral valve is closed, and we have this isovolumetric contraction in which all valves are closed. So why we do it? Well, we want to build up the pressure. Notice for me, please, here. Here we have left ventricular volume. So this is the change of the left ventricle volume, how much blood in the left ventricle. And on this y-axis, we have the left ventricular pressure, how much pressure inside of the left ventricle. If we speak about the isovolumetric contraction, the volume, it's isovolumetric, it's the same, nothing will change. So on the x-axis, it will stay the same, nothing will change. But on the pressure axis, well, there is a buildup of pressure inside of your left ventricle. And that's the main idea. So the pressure will build up from around 20 and will go up like this. Up, 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 up. So it has reached 80. Why at 80 exactly the aortic valve opens? Why it does not open at 120? Why it does not open at 60? Why exactly at 80? Well, for that to understand, guys, we have to draw really quick a scheme of the heart. So you can see here left atrium, left ventricle, and an aorta. If we speak about the pressure in your left atrium, most books say under 12. The pressure inside of your left ventricle, it's like 130, or some books write 120 over 10. So the pressure inside of your aortic arch, please, this is know that this is the aortic valve. So the pressure inside of your aorta will be like the same pressure you check by blood pressure cuff, 120 over 80. So for this valve to open, the aortic valve, it has to exceed the diastolic pressure of the aorta. So during diastole for aorta and systole for the left ventricle, what happens? The pressure inside of the left ventricle exceeds the 80. It's more than 80. While the pressure here will be 80. Yeah? So if it's more than 80, it's just a gradient. The valve will open. The valve will open, there will be movement of blood. So when it reaches the pressure, when it reaches 80, the valve will be open. Notice here, the pressure here is building up, 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 up. The moment it has reached 80, the aortic valve has opened. So aortic valve has opened. So what happens next? Well, when the aortic valve is opening and all of that contraction was accumulating, and the pressure was accumulating, there will be shoot out from the left ventricle to the aorta. It's like an ejection type of thing. So the left ventricle will eject all of that blood out. Please notice that it's the black graph, not the brown or the green one. It's the black one. So the ejection will go from here until here. So notice there is two things changing. The volume of the left ventricle, because this is represent the left ventricle, the volume is decreasing because the more you go to the left on x-axis, it means the volume has decreased. So the volume in the left ventricle is being decreasing. And the next thing that is happening, that initially you have increase in the pressure in the left ventricle, and after that something else happens. We'll speak about it. So let's speak what is happening exactly. So we call this systolic ejection. Systolic ejection. So okay, remember what I told you guys in the beginning. Systole is the period between S1, here it is, and S2. And I told you that the S1 is a representation of the mitral and the tricuspid closure, but since we are speaking only about the left ventricle, the only valve that is important is the mitral. And the S2 is the aortic and the pulmonic, and since it's the left ventricle, the only valve that is important will be the aortic. So if they ask you, can you show us on the graph, please, which period represent the systolic blood pressure, the systole? It will be from S1 until S2. But these guys are tricky. They don't put S1, they don't put S2. They just show you the graph and put you arrows. So you have exactly to know where each valve open, where each valve close. And most of the time the question comes like, which valve opens here, which valve opens there. And it just like, if you understand it, it makes sense. You don't have to memorize it. So next thing we have happening, so we spoke about Isovolumetric contraction, which is the period between mitral valve closing and the aortic valve opening. And so we have the aortic valve closing and the aortic valve opening. I just got a message that there is some sound. Someone forgot his microphone, I guess. Just a second. Only closed. Okay, back to this. So we have Isophylometric contraction. It's the period between the mitral valve closing and the aortic valve opening. So it's when between the mitral valve has closed and the second thing, the aortic valve has opened. When does the aortic valve opens? Here. And you must know this area. Why does it open? Because the left ventricular pressure has exceeded the aorta diastolic pressure. Okay, and they write it's period of highest O2 consumption. Why it's the period of highest O2 consumption? For the heart to contract at that effort, he needs to have the massive amount of contractility. And remember from the previous class, we spoke that increase in the contractility, increase in the O2 demand. Yeah, so more O2 demand, more O2 consumption. Good. So the next thing we have is the systolic ejection. It's the period between the aortic valve opening and the closing. It's between the period that the aortic valve opens and the close, which lead to the ejecting all of the blood outside of the heart. Okay, so that was period between aortic valve opening and the closing. Now I hope this area makes sense. It's important. Now the other area becomes much more easy. So we have the Isovolumetric relaxation. Again, when I tell you Isovolumetric relaxation, which valve is open? Excellent, no one. Anytime you hear the word Isovolumetric, no valve is open. All of them are closed. So Isovolumetric relaxation is the period between the aortic valve being closed and the mitral valve being open. So if we speak about the aortic valve closing, it's here. And the mitral valve opening is there. So why this happen again? So the pressure, you have ejected all of the blood from your left ventricle, okay? And the volume, the end systolic volume has been reached. So you have minor amount of blood in your left ventricle. So the pressure started dropping. When the pressure started dropping, your aortic valve, it goes like down, like when the pressure inside of your aorta goes up because you put more volume in it, and then your left ventricle goes down because you have less volume in it, the valve will close. When the valve closes, what will happen? Time for isovolumetric relaxation. The mitral is already closed, the aortic now closed, so everybody closes and the pressure goes down, but the volume is the same. That's why we call it isovolumetric. When it reaches this point, it's less than 20, guys. It's actually less than 10. When it's less than 10, let's go back to the graph. When it's less than 10, the pressure inside of the left ventricle, the pressure moves from your left atrium down to your left ventricle. Because here it's 12 and during diastole, here it's 10. So the pressure just go with the gradient, guys. So mitral valve has opened, and now we have the filling process. So initially we have rapid filling, then we have reduced filling, and I will explain for you exactly what it means. Super important to know the difference between these two. But first of all, let's speak about the isovolumetric relaxation. So they write for you, it's the period between the aortic valve closing and the mitral valve opening. Okay, so now before telling you about the lower portion here, I want you to know the following. This is the end diastolic volume at this area. This is the end systolic volume. You remember in our previous class we said the end diastolic volume, which is the period in which we accommodated the most amount of blood during the relaxation of the heart, minus the end systolic volume, which is the period in which we accommodated to the least amount of the blood in the heart after the systole. The difference between these is called the stroke volume, and the stroke volume is proportionally related to the contractility. Good. So here we have, if you see the difference between them, that's the stroke volume. Good. So let's take a look here. The mitral valve has opened, and now we have something called the rapid filling. So what does that mean? This guy has just opened the mitral valve, and the blood is moving fast. It's like all of it, like with the gradient is going down. Cool. So that's rapid filling. It makes sense. No problem. What is this reduced filling? Well, after all of the blood has went down, there is a little bit of blood left in the left atrium itself. So the left atrium feels like a little bit of blood is still inside of him. So he does this. One last push. The left atrium itself contract, okay? So again, we have the rapid filling. It's due just to opening of the valve. And after that finishes, the left atrium feels that there is still some blood in it. So it pushes that small amount out. And that small push, like the contraction of the left atrium, lead to the reduced filling. So here they write, rapid filling period just after the mitral valve opening. Okay. And then we have the reduced filling, which is the period just before the mitral valve closing. Write a note next to it that it's due to the atrium contracting. And that will be important in 1 second. You will see why. So you have to know where each valve is located, each valve opens and closes. And the next thing you must know is the additional sounds, the S3 and the S4. So let me speak about the S3 and the S4. So if we have this cardiac cycle, we have the S1 and we have the S2. Okay guys, so S1, S2, you know what each sound mean. S1, we said it's a closure of which valves? It's a closure of the atrioventricular valves, which are tricuspid and mitral. You know, we said AV valves are the valves that is located between the atria and the ventriculi. And the S2 is due to the closure of which valves? The semilunar valves, which are the valves located between the ventriculi and the other organs, like the lung and the systemic circulation. So now comes extra sound. So remember when I told you that the cardiac cycle is actually a cycle, but we draw it like I draw it in the beginning, because for simplicity's sake. So here we have an S2, and here we have S3. What comes after 3? Correct, 4. So it's an S4. So it's 1, 2, 3, and 4. Notice that the sound is pretty close to the S1, S2, S3, S4. So 2 is close to 3, 4 is close to 1. Okay, how does that sound? Well, first of all, guys, I want to teach you how can you listen to it. Because if you cannot listen to it in the clinic, this is all theory. It's useless, sorry, but it's useless. You have to know how to use this in the clinic. To use it in the clinic, if you have a stethoscope, you look at the stethoscope and it has two portions. Okay, so the stethoscope has a diaphragm and it has a bell. So this is the bigger portion we call a diaphragm, the smaller portion we call a bell. And yeah, this is a stethoscope. To listen for an extracardiac sound, you have to use the bell, sorry, with a B, the bell of the stethoscope, not the diaphragm. And you have to tell the patient to lay in a recombinant position on his left side. It's like sleeping on your side in a baby position. So you put your knees against your chest and you make him lay on his left side. Why? So the heart will be pushed more against the chest and it will be more easy to auscultate it. So, and you will listen with the bell or with the diaphragm. Correct, with the bell. Okay, so that's how you listen to it. So what are you going to hear? For S3, it will be too close for S2. And for S4 will be too close for S1. But still, you don't know how it sounds. So let me make the sound of S1, S2 for you. So S1, S2 goes something like this. So S1, S2, S1, S2. So sounds good. S1, S2, S1, S2, and there is little breaks between them. Notice please that the period between S2 and S1 is much longer than the period between S1 and S2. Okay, let me now make for you an S3. So that's an S3. You hear like one sound, break, two sounds. One sound, break, two sounds. This is the one sound here, break, two sounds. Okay, what about an S4? Well, in S4, the S4 sound and the S1 sound are too close to each other. Then we have a break, and then we have the S2, S3. Okay, so let's speak about the S. If we only have an S4, so it will be something like this. Notice, two sound, break, sound. Two sound, break, sound. Okay, what about Gallop Rhythm? Gallop Rhythm, it means that you have both S3 and S4. Kind of difficult to do, it goes something like this. We say about it, it's like horse walking, okay? So, okay, let's go back to speak a little bit more. So that's how you listen to it. So what does it mean? That's why you came here, to understand. So S3 is due to dilatation of the walls of the left ventricle. So they dilate, they become bigger, so they can accommodate for more blood. Okay, guys? Why they become dilated? Well, it could be hereditary, like some condition, hereditary condition, we'll speak about them in the future. Or it can be volume overload. For example, if you have an aortic regurgitation, blood going back to your heart, that will lead to dilated cardiomyopathy and an S3. So what is exactly S3? S1 we said what it is, S2 we said what it is. So S3 is due to after the what happens at S2. If you remember, we spoke that the semilunar valves are closed, and which valves are open? The mitral valve. So what happens that normally the blood should like pass in the rapid filling from the left atrium to the left ventricle. But what happens is that the left ventricle is so big for it. So there will be passing of the blood in a way that it will be just turbulence with it. So there will be this sound like turbulence, because they are hitting walls of a dilated ventricle. It's like if you have water, if you have a bucket, big bag, and you put a lot of water in it really quick, it makes this sound. Or if you see like a river going inside of the sea, the moment it hits the sea, it makes a sound. That's an S3. Okay, what about an S4? An S4 is due to a stiffened ventricle. So it's like you just had lunch and the heart is super full, and it's like it's super full, but still you try to squeeze a little bit more for the dessert, and that leads to little vibration from the left ventricle or from your stomach. This is the S4. So it's pushing against the stiff ventricle. This is S4. Pushing against the dilated ventricle. This is an S3. Okay, guys? Good. So let's go back to this. I took some time on that, but it's kind of an investment because it will be helpful for us explaining most of the next concepts. So let's speak about the other graphs here that they represent for us, the pathological one. Let's speak about a state of increased preload. Well, here is everybody opens his telegram to the side. Now you will have to answer some question from material we got before. Okay, can someone write me please, when do we get increased preload? Can someone write me a condition in which we have increased preload? Excellent, pregnancy. Good, it's a pregnancy. Well, hypervolemia, good. So yeah, what is IVF? And not sure what is IVF. Okay, but yeah, hypervolemia and pregnancy, that all lead to increased preload. If you increase your preload, if you remember from our previous session, previous time, we spoke about how increased in the preload can actually lead to increase in the stroke volume. So that will lead to an increase in your stroke volume. If your stroke volume goes up, your first of all, increase the preload, the amount of the blood in the left ventricle during end of the diastole will be higher. Do you remember, guys, when we explained the preload and how it means that there is increased amount of blood inside of the left ventricle? Yeah. So your end diastolic volume, this one, will shift to the right. Yes, because your left ventricular volume during the end of the diastole will be much higher. Okay, so it will be much higher, and whoop, we had a contraction and the cycle happened. Exactly the same. The only thing that was different here was what? The amount of the preload, which led to what? Increase in the end diastolic volume. So far, so good. Okay, the next concept will be increase in the afterload. So when your afterload is increased, what happens? You have more aortic pressure. For example, what can lead to increased aortic pressure? Can someone write that? Something increasing aortic pressure. Well, here is the thing. It's true that aortic stenosis can lead to increased afterload. But what about something after the aortic valve, like inside of the aorta itself? Yes, peripheral resistance. What increases peripheral resistance? Hypertension. Excellent. So, or aortic stenosis, like the guy who wrote aortic stenosis, you are actually right. So let's imagine a condition of aortic stenosis. If you have aortic stenosis, your afterload will go up. What will happen to your stroke volume? Stroke volume down, exactly, it could go down. Good. And the end systolic volume will also be reduced, exactly. No, end systolic volume will be higher. Why? Because you are ejecting some blood, but the valve is closing right away. So let's speak about it. Okay, so what happened here? The aortic valve opening. Remember, guys, when I told you about stenosis, it has an O in it. So O for in stenosis means a problem in opening the valve. Yes? If the valve has really difficult time opening, that means what? You are unable to open the valve, and that means you will have longer period of the valve being closed. So actually, in case of aortic stenosis, like the one in blue here, it's taking you much more time to open the valve, and it's only opening here. So when it opens, you have ejection, systolic ejection, but it's super short. Why? Because the resistance is super high, he cannot handle it. So it will shut back again at much higher volume because the peripheral vascular resistance is much higher than he expected. Yeah? So it will shut down again super quick. And then it will go down. Notice what has happened here. First thing, what happened to the end diastolic volume? Same. What about end systolic volume? Yeah, it's normal. It's the same. See, guys? It's yeah, but the end systolic volume is increased. Absolutely correct. And if you speak about the stroke volume, they ask about this one. Decreased. Excellent, everybody. Excellent. Good. So yeah, it's actually decreased the stroke volume. Why? Because the end systolic volume has increased, so the stroke volume overall has decreased. has shrunken down. I hope that makes sense. So far we have spoke about the increased afterload, increased in the preload. So we are left with increased contractility. Can you guys give me some condition we studied yesterday that increase contractility? Sympathetic activation. What else? Digoxin. Excellent, excellent. What else? Come on, one more, one more. Atropine is correct. Exercise. I'm not sure how CAT can increase your sympathetic activity. Well, anyway, drugs, yes. So digoxin. Excellent, guys. Dopamine. Okay, all good. So contractility. So if we speak about contractility, it's our trustworthy type of thing. So the contractility, when it's increased, it can be increased due to digoxin. So when digoxin is utilized, if you remember which channel is blocked due to digoxin, positive inotropic drugs, yeah, correct. So it's not the calcium channel blocked, no. Which channel is blocked in case of digoxin use? The calcium is increased inside of the cell, but it does not mean that exactly sodium-potassium channel, and that leads to increased amount of calcium inside of the cell because the sodium-calcium exchanger is not working, guys. Okay? Indirectly inhibit the sodium-calcium channel, which increases the calcium inside of your cell, and that leads to increased contractility. I'll be sending you a couple of pictures about this after the class. So, okay, guys. So far, so good. Let's speak about the increase in contractility. So we have a condition, for example, someone is exercising or he's taking digoxin. So the end diastolic volume is perfecto. But if the contraction happen, the contraction is so strong, so the stroke volume is much more higher. This is the stroke volume. So he will be pushing more. The systolic ejection is much more higher. So the aortic valve cannot close because the power is so high against him. So all of this blood will be ejected out, and after all of that has ejected out, what will happen? Closure. So the end systolic volume will be much more reduced. Why? Because all of that blood was pushed outside. So what is this? Ejection of fraction. Ejection of fraction will be obviously increased because in ejection it was increased. Guys, which condition we spoke about yesterday? If you have ejection of fraction less than 55, you have that condition. Which condition was it? Excellent, systolic heart failure. Wow, he was even more specific. He wrote systolic. Excellent, because diastolic have it normal. Good. So let's take a look at the next graph. Guys, this graph is difficult, I know, but the thing is we need to look at it one piece at a time. If you look at it all pieces at a time, it's confusing. So we will take each piece at a time and then we will start connecting them to each other. So let's do this. First portion we have is up here. So we have to utilize only one. Guys, forget about all of the drawings here. I want from you just to know the heart sounds now, and then I will be adding these one by one. So in the heart sounds, what is happening during S1? During S1, we have a closure of which two valves? We said it's the mitral and the tricuspid. As you can see here, they write mitral valve closure. I do not want you now to know what is this. Just know that it's mitral valve closure during S1. S2, what will be closing? The aortic valve closing. Good. So initially you have the isovolumetric contraction. This is happening during systole, early systole. Then you have rapid ejection. I hope you can imagine how it's going from the right to the left. That was rapid ejection in the graph above. So that was rapid ejection, guys. And then you have what? You have reduced ejection. What is the difference between rapid and reduced ejection? Take a look here, guys. From this area until this area, this is rapid ejection. And then it becomes reduced ejection. Rapid, reduced. Rapid, reduced. Okay, let's take a look. So all of this is systole. Systole is done. What about after that? Diastole. So the diastole, where it starts? Here. At the S2. So the S2 starts and we have isovolumetric relaxation. So the heart relaxes, you remember the graph, and then we have rapid ventricular filling, and then we have reduced ventricular filling. And do you remember after the reduced ventricular filling, what does the atrial do with what is left of a blood inside of it? Yes, exactly. One last push. Atrial systole. Okay? Because remember, guys, it's a cycle. So it goes from here and it returns back here. Okay, so we understand the heart sounds. Let's add one more. Let's add this, but not the whole thing, one piece at a time. So let's add, first of all, what is this? This is the pressure inside of different chambers inside of your heart. Let's start from the aorta, since it's easy to speak about it. The aorta is in pink, guys. So this is the aorta, okay? It's in the pink. So initially, during diastole, do you remember what I told you the pressure inside of the aorta was? 120/80. So during diastole, it's 80. So since it is 80, it's here. See? That's how I knew that it was the aorta and nothing else. So, and the aortic valve opens at 80. Why? Because at 80, we have opening of which valve? Excellent, everybody. It is the aortic valve opening. And during the same time we have had the mitral valve closing. So yeah, but wait a second, there is a lag between the mitral valve closing and the aortic valve opening. That means during this lag here between these two, all of the valves inside of your heart used to be closed. So we call that what? Isovolumetric contraction. Okay, so the aortic valve opens and it shoots out all of the blood outside, and then it reaches the tip, and then it like back low, which is like the reduced ejection. But still, blood is going out from the left ventricle. When it goes down to a certain degrees, the aortic valve closes. It shuts down. And what happens? Well, it starts to accommodate to what it got, like the aorta itself. I want you guys to appreciate this dichrotic notch. A lot of people don't understand why it happens. Guys, if you imagine this, oh, that looks bad. Okay, let me clean it a little bit. Okay, if you imagine this, this blood has accumulated here, and the pressure here is already 120. Okay, and now it's time to like you ejected the blood out, all good, and now it's time to close this valve. The moment you close this valve, what happens? Imagine this, guys. You are closing the valve, you're shutting it down suddenly. That will lead to one more kick of the blood. Like it's like there is some blood accumulating here. Okay, guys? Imagine it's like Agent 991. They are hiding here, the blood, the last amount of blood, and you close this valve. And the moment you close it, it's like whoosh, the last push, basically. And that last push lead to what? Correct, the dichrotic notch. Okay, it happens exactly at the aortic valve closing. And then you can see even like a little bit of overshooting of the blood inside of the aorta, and then it goes back to the diastole. Because it slowly goes back to the heart. It goes back to the systems all over your body to distribute the blood all over the body. So, okay, that was the pink graph. That was only about the aorta. Now let's add one more vessel. The next vessel I'm adding will be, the next chamber I'm adding will be, oh, it's one late. Okay, the last chamber that I will be adding now, it's quite interesting, will be your left ventricle. So your left ventricle is, you remember the pressures inside of it? I told you it's between 120, 130 according to which book you use, divided by how much? 10. Yes, excellent. It was 10. It was here. So that 10, here it comes. See the 10? So this is the diastole. So what happens when it's 10? We have passage of blood from the left atrium to the left ventricle. How much was the pressure in the left atrium? It was around 12. Okay. So we have like passive passage of the blood to the left ventricle. Okay. So then S1 happens. What happens at S1? that is super important for the left ventricle? Well, the mitral valve closes. Well, when the mitral valve closes and the aortic valve at that moment is also closed, so we have isovolumetric contraction in the ventricle. So you can see the pressure inside of the ventricle is rising here. Yeah, isovolumetric contraction, like the same graph as above, but different perspective of it. And when it reaches 80, remember we spoke about it, the valve opens. And we have an overshoot and rapid ejection, then reduced ejection. Okay? But then what happens? You have ejected all of the blood outside of the left ventricle. Like, yes, the pressure is still high, but the volume has reduced significantly. So the relaxation of the left ventricle starts. The walls of the left ventricle need to relax. Why? So they will get the blood back. So initially we have the isovolumetric relaxation. So isovolumetric relaxation take a part and it drops the blood pressure from like almost 100 down to 10. And when it reaches 10, what opens? The mitral valve. Why it opens? So you will have filling of your left ventricle. Remember about the filling, it happens in the three steps. First step, rapid filling, which happens like because you just opened it and all of the blood is dropping down. The next step is reduced filling, just like you are passing a lot of blood, then little bit of blood. Then the left atrium will be like, come on guys, just get me all of that blood out so I can relax again. So he decides to contract. So we have atrial systole, as you can see, little jump. See guys, this little jump, it's super important. Don't miss it, there's a little jump here. And after that little jump happens, like the left atrium get relieved and he closes the valve again. And the cardiac cycle repeat again and again. Okay, so we spoke about the aorta, we spoke about the left ventricle. Now we have to add one more chamber. The next chamber I'm going to add is the left atrium. The left atrium, imagine this with me guys. The left atrium, where he does get the blood from? Correct, pulmonary vein. Regardless of the fact that it's vein, it has oxygenated the blood. Why we call it vein? Because it comes back to the heart. Any vessel that goes back to the heart, we call it vein, regardless if it was have oxygenated or non-oxygenated blood. So in case of mitral valve, in case of left atrium, what happens? Well, now I'm going to start from a different area. I'm going to start from the top left. Or actually we can start from here. Let's start from here. It doesn't matter, it's all the same. So at this moment, the mitral valve has opened. Why he has opened? So he will fill the left ventricle. So the amount of the pressure from the left atrium is being reduced. See the pressure inside of the left atrium? It's going down. It's going down like this. We call it the Y descent. I will tell you more about it when I come back to it now. So there is the Y descent. And after this Y descent has occurred, what has occurred? Y descent, Y descent, Y descent. It's going down, 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 down. Remember when I told you that when it gets all of the blood outside of it, he decides to give it one last push? Now that one last push is super important. It is atrial systole, which creates you something called the A wave. You must know the A wave for the atria. Okay, so this is the A wave. It happens due to what? Atrial systole. So which condition will lead to its absence? When the atrium is not having a systole. Which condition have absence of the systole? Atrial fibrillation. So in atrial fibrillation, you have absence of the A wave. Well, can we check the A wave? Of course we can. Otherwise, we will not have it in the book. But I will be telling you how we check it after the break, actually, which is in 3 minutes. But let's take a look here. So we have here the mitral valve has decided to close after he got all of the blood inside of the left ventricle. So after that happened, we have isovolumetric contraction of what? The left ventricle. So how come it affects the left atrium if the contraction is happening in the ventricle? It does not make sense. Well, it does. Look here, guys. This ventricle is contracting, yes? If you contract this ventricle from all of the sides, you are contracting it. The amount of the blood during isovolumetric contraction, which valve is closed? All of them. So this valve, this one, the mitral valve, will be bulging up. Okay, guys? So normally it's here. During isovolumetric contraction, it will be bulging up. I'm not saying it opens up. No, it's just bulging. And if it's bulging, according to the Laplace law, we said about it yesterday, if you make any diameter smaller, what happens to the resistance inside of it? It goes up. So what happens to the pressure? It go up. So let's take a look what happened. During isovolumetric contraction of the left ventricle, we have bulging up of the mitral valve inside of the left atrium, and that led to what? Creation of the C wave. You must know the C wave and the A wave. So we spoke about the A wave and we spoke about the C wave. Okay, now we have an opening of the aortic valve. All of the blood was ejected from the left atrium to the aorta. It was ejected out. So the amount of the blood inside of your left ventricle, what happens to it? It has been reduced. Yes? So now not a lot of blood here. Blood has been ejected out. So this bulge just go back to normal. It becomes flat again. So the pressure here, it drops significantly. And that drop, we call it an X descent. Okay, guys? It's an X descent. Okay, and then we have like normal pressure here, all good. And then something interesting happened. We have isovolumetric relaxation. That does not sound good. Your left ventricle is relaxing, yeah? So if your left ventricle is relaxing, but the valves are not being opened, during this period, which is between the beginning of the X descent until the V wave, until the Y descent, all of this is called the V wave actually. What is happening? Well, your left atrium itself is filling, okay? So V for filling, okay? V for filling. V, filling. Where it is filling from? Correct, the pulmonary veins. So the pulmonary veins are ejecting blood from the pulmonary veins to the left atrium. And that leads to the creation of this slope. Okay, guys? And when it reaches this point, the mitral valve opens because the pressure in it is higher than the left ventricular pressure. And we have a Y descent due to the passage of the blood. I hope that makes sense. If it does not, don't worry about it. We'll be explaining the exact same after the break about it, but on the right heart. Okay, guys, if that makes sense, nothing else will be difficult for you in cardiology. So let's have a 10 minutes break now, and we will continue after the break. The break ends at 7.2. Okay, 7 o'clock, 2 minutes. Hello everybody, welcome back. So I hope what I just explained made sense. If it did not, it's okay. Now we are going to add more stuff to this graph. As I told you, this graph, you cannot understand all of it together. You have to attach pieces to each other. It's like puzzles. So if we speak about the ventricular volume, which is exactly the same thing as here, just to check, yes, I'm unmuted. Okay, if we say initially, let's start from here. We have isovolumetric contraction. During isovolumetric contraction, what happens to the volume? Well, it's obvious, nothing. So anytime there is isovolumetric, it's a flat. Nothing changes on the volume inside of your left ventricle. Okay, so what happens after the aorta opens? The volume inside of your left ventricle drops. It's just obvious. We have the rapid ejection, reduced ejection. And then here at this point, we have the closure of which valve? Correct, it's the aortic valve, in which all of the valves now are closed. This is isovolumetric relaxation. And then what valve opens? The mitral valve. And what happens when the mitral valve opens? The blood starts moving from the left atrium to the left ventricle. And when that blood starts moving, we have rapid ventricular filling, reduced ventricular filling. And do you remember, guys, what happened in the end? What did the atrium do? He wanted to do that one last kick, the atrial systole. So one last kick, adding a little bit of volume to the left ventricle. That's it. Okay, so the next graph is regarding the, let's actually speak about the right atrial pressure curve. This one is super interesting, guys. We just spoke about it, but from the other side. Like we spoke about it from the left atrium. Now we are going to speak about it in the right atrium. Why it's more important in the right atrium than the left atrium? Because in the left atrium, you cannot visualize it. You cannot see it. But in the right atrium, you can actually see it and you can measure it. So let me show you what I'm speaking about, guys. So if we say GVD, do you know what does it mean, GVD? Jugular venous distension. The jugular venous distension, we have something in your neck called the jugular vein. This jugular vein is basically what drains all of your head to your superior, no, not this, oh yeah, this one. You can see here, jugular vein distension. I will teach you a trick, guys. So if you want to check if this patient just have it normal in his neck, like the GVD, or is it pathological, there is a trick. So the trick goes something like this. Let me show you so you will be able to, yes, it goes something like this. You bring the patient, you raise his bed by 45 degrees. Okay, guys? After you raise the bed, come on. After you raise the bed by 45 degrees, you look at his sternum. Okay? At the top of the sternum, there is the meninbrium. And exactly at that point, you draw an imaginary line. Okay, guys? You do an imaginary line. Okay. And then you take a look at that GVD. So if that GVD, you see how high it is. If it is more than 3 to 5 centimeter high, that's diagnostic of GVD, jugular venous distension, which tell you the blood is not moving to the right atrium, or the right atrium has a stasis of the blood. Guys, think about it. When we spoke about the connection between the right atrium and the right ventricle, we said we had the tricuspid valve. But what about the connection between the superior vena cava and the right atrium? There was no valves. It's a direct communication. That means so that whatever pressure you have in your right atrium, in your superior vena cava, in your inferior vena cava, and in your GVD is exactly the same. This is important because from looking at the neck, you can determine what is the pressure in the right atrium. So conditions such as tricuspid regurg will increase the right atrial pressure. Conditions such as COPD. We will speak about COPD in details in the future. And also we have conditions such as pulmonary stenosis, conditions such as right heart failure. All of these will lead to GVD. You will be able to see it with your eyes on the patient and you will see it on the exam. So here it goes something like this. Again, we have the, let's start from here. So at the Y here, what we had what has happened, if you remember, guys, we spoke about the mitral valve opening. But since this is the right heart, it will not be the mitral valve, it will be the tricuspid valve. So exactly at the end of Y, the tricuspid valve opens. Why it opens? So it can fill the right ventricle. So it starts filling. The slope is super, like not that significant, you know? So, but it has a slope going downward. At the end of filling, what happens? The atrium decides to do systole. That's important. Why? Because it creates your A wave. A wave is absent in which condition? Afibrillation, AFib. A wave absent in AFib. Okay. After that, we have the contraction of your right ventricle. When you have contraction of the right ventricle, your tricuspid valve will be ballooning up or just bulging up inside of the right atrium. That bulging up is creating what? The C wave. I just imagine like this is like a hat. It's like the mitral or the tricuspid valve like bulging inside of the left atrium and the right atrium. You know, guys? It's like a hat. And then we have the X descent, and after the descent, what is the X descent? It's when the tricuspid or the mitral valve return back to their normal places because the blood has been ejected outside of the heart. And then we have the period in which in the left atrium, it was the pulmonary vein filling the left atrium, and in the right heart in the right atrium, it is the superior and inferior, and the coronary sinus filling the what they are filling? They are filling the right atrium. Okay, guys, I hope it makes sense. So, last thing we are going to speak about is ECG. So ECG, I will not take a lot of time on it because we will take a lot of time on it like next class, I think. So ECG, we have the B wave that represents the contraction of the atrium. Contraction of the atrium. Oh yeah, remember guys, atrial systole. And the QRS complex represents the contraction of the ventricle. Yep. When the ventricle contracted, we have the creation of the C wave. And it was the isovolumetric contraction. At that period, a little bit after it, at the end of it, the aortic valve has opened. It was after the mitral valve has closed, it started contracting. And you see guys, all of these are connected together. So the next thing is the T wave. T wave is a repolarization of the ventricle or the atrium. The ventricle. A lot of students tell me, okay, I get it. Like B wave is depolarization of the atria, which means like contraction of the atria. QRS complex is depolarization of the ventricle, which means contraction of the ventricle. But what I cannot get, that you say that T wave is repolarization of the ventricle, like relaxation of the ventricle. Where is relaxation of the atrium? You did not mention relaxation of the atrium. Where does it exist? I cannot see a wave in it, about it. Well, yeah, you cannot see it because it's hiding inside of the QRS complex. You cannot see it because it's hiding inside of it. Because the period where the atrial relaxation actually has occurred was during the formation of the QRS complex. So you could not see it. That's why. Because it occurred immediately after the atrial systole. Yeah? So it's hiding somewhere inside of the QRS complex. That's why you cannot see it. So we have explained all of this. Why we did the graph before reading. Because if you do the reading before the graph, it will be like reading magic. You will understand nothing. Now we will be reading and everything will make sense. Okay, so heart sounds. S1, mitral and tricuspid valve closure. Loudest at the mitral area. Where is the mitral area? It's near the apex. Where is the apex? It is at the 5th intercostal space, 2.5 centimeter, right to the mid-clavicular line. On the left, of course. If it was exactly what I just said, and it was on the right, which condition it will be? Let me see Telegram answers. Dextrocardia, which is a condition in Dianin arm, yes, but Cartagena syndrome. Excellent. So yeah, I was asking which condition you will have the apical impulse of the heart, which is normally located at the 5th intercostal space, 2.5 centimeter right to the midclavicular line. If you will have exactly the same, but instead on the left, you have it on the right, that means that your heart is shifted to the right. That was in Cartagena syndrome. And can someone tell me why these patients are infertile? That's correct, yeah. Why they are infertile, they cannot have babies. Well, in men at least, someone right, in men. No motile sperm, yes, sperm do not move, and in ladies inside of the fallopian tube, there is cilia that moves the egg. So that also is not moving, guys. So that's why in ladies there is also decreased fertility. You can do in vitro fertilization on them and it works perfectly. So the S2 is aortic and pulmonary valve closure together, and it will be loudest at the left upper sternal border. I will speak about exactly the location in a moment. Don't worry too much about it now. So the S3, in early diastole, during rapid ventricular filling, it's best heard at the apex when the patient is at left lateral recumbent position. Decubitus position, recumbent position is kind of the same thing. Let me show you how it looks like. It's like being like a baby, but on the left side. So, yes, it's something like this. It's really important in some surgical techniques because you want to move the organs at one location over another location to make it easier for you to deal with the patient, you know, guys? Yep. So you put it to his side, basically. and you would like also him to raise his knees a little bit, exactly like this. Okay, why we do that if we want to listen to the heart? Because you want his heart to be stuck to the wall of the chest, so the sound will be more clear. And you listen to it with the bell, not with the diaphragm of the stethoscope. Okay, so the S3 is associated with a filling pressure, like a mitral regurgitation, aortic regurgitation, heart failure, and thyrotoxicosis. Basically, anything that leads to hyperfilling of the heart. In mitral regurg and aortic regurg, we have more blood inside of the chambers. In case of heart failure, like he means in dilated cardiomyopathy. In case of thyrotoxicosis, we have high output heart failure, which I will be explaining soon. Also, you can add that in cases such as AVMs, arteriovenous malformation. Also, in Batchet disease of the bone. Also, in case of a creation of a fistula in a dialysis patient. Also, it can be in someone with a traumatic fistula creation, which is like someone stabbed after some times, he have heart failure. That is increased cardiac output heart failure. We'll be explaining that topic in details when we reach heart failure. It's one of the most high yield, super important topics. Okay, so they write, and more common in dilated ventricles, but can be normal in children, young adults, athletes, and pregnancy. So the S3 sound can be common when the ventricles are dilated. So who has S3 to be normal? Well, it includes normal in children, young adult, athletes, and the pregnant lady. So guys, be careful about the question that will come something like this. They will tell you, they will give you like one of these heart sounds questions, and you will be like, you will listen to it, you will flip the stethoscope, listen to it with the bell using the application they provide, and you will hear something like this. You are like, oh, this is S3, I know it, easy. Okay, where do I choose S3? Oh, it's not, they are asking me the cause. Dilated cardiomyopathy, heart failure, mitral regurg, aortic regurg, and normal. You look at the age. That's the first thing you do, guys. Look at the age. If the patient is young, less than 35, it's normal. If he's more than 35, it's pathological. So I actually have this trick that I use for myself. I tell myself it's 35 here. Anything under 35 is S3 is normal. Anything more than 35, S4 is normal. Okay? So in young people, S3 is normal. In children, athlete, pregnant lady, because they have more volume. And yeah. So in case of and you remember why the sound occurred actually. It occurred when we said that there is this rapid ventricular filling against a dilated ventricle. It's like a river pushing inside of a sea. That sound, that like that thing is the S3. So lastly, we have the S4. The S4 in the late diastole, we have an atrial kick that is best heard at the apex with patient in the left lateral decubitus position. So what does that mean? Again, the same position we just spoke about. And what does it atrial kick mean? Well, the left ventricle will be really stiffened. It's really stiff. And you are pushing against a really stiff ventricle. It's like your stomach is full and you eat one more thing. It will start vibrating. That vibration, it's S4. So atrial kick, one last kick. So it's best heard at the apex with the patient in the left lateral recombinant position. So remember what created one last kick? It was the atrium here. Remember? So that created the S4. It was one last push against that stiffened ventricle. So there will be high atrial pressure, obviously, and is associated with ventricular non-compliance, such as in case of hypertrophy. Can heart undergo hyperplasia, guys? Good. No, never ever hyperplasia, only hypertrophy. Good, because it's one of the stable tissue. It's stuck in the G0 phase, which we'll explain in hematology oncology. So here we have associated with ventricular non-compliance like hypertrophy, and we have, they write, the left atrium must push against a stiff left ventricular wall, and that's what creates the sound. It's considered abnormal if you are able to palpate it with your hand without having to put a stethoscope in the chest, you know? And guys, remember, it's normal in any person who's more than 35, okay? Less than 35, pathological. Okay, let's speak about what's written here. We have jugular venous pulse. So we have A wave, C wave, X descent, V wave, and Y descent. So in A wave, it's atrial contraction. It's absent in atrial fibrillation. So let's speak a little bit about the A wave. Remember, guys, about A wave, I told you that it's when the atrium was contracting, and it will be absent in what? In AFib. So I write here in AFib there is no A. Yeah, atrial fibrillation. Okay, that's super important. Because what does fibrillation mean? Fibrillation means it's like the left atrium is vibrating, guys. Vibrating. It's just like, but it's not really contracting. It should contract like this, and it's just doing something like this. So the blood is not moving. If it's not moving, the volume and the pressures will not change. So the A wave will be absent. Okay, guys? So next is the C wave. So here they speak about the right ventricle. So right ventricle contraction against a closed tricuspid valve will lead to the tricuspid valve to be bulged up into the atrium, creating what? This hat-shaped thing. Yeah? So the pressure will be increased. Okay, guys? So the next one is the X descent, which is a downward displacement of a closed tricuspid valve. Why would the tricuspid valve go back to its place? Well, because during rapid ventricular ejection phase. So the blood goes out from the right ventricle, so the tricuspid valve go down back to its place. Reduced or absent in the tricuspid regurgitation, and in case of right heart failure, because the pressure gradient is reduced. So again, the X descent will be reduced in some condition. Which condition? Imagine this person, just a second. Imagine this person having what? Having regurgitation. Okay, guys? So if he's having regurgitation, well, the tricuspid valve, tricuspid regurg, the tricuspid valve will not be able to close fully. Yes, because it's a problem in closing the regurg. So so the volume inside of the right atrium will be something like this. So normally when the tricuspid valve closes, it goes down like this. But what happens here? It comes like this, and then when it's time to close, what happens? The blood from the right ventricle stay inside of the what? The right atrium. Yes, guys? So the X descent is lost. So they write for you. Reduced or absent in case of tricuspid regurgitation and right heart failure, because the pressure gradient will become reduced. So yeah, I hope it makes sense. During heart failure, right heart failure, or in case of tricuspid regurg, the right atrial pressure will stay high. Thus, the X descent will disappear. The next one is the V. It's the V wave, it's the filling. So the filling of what? The filling of the right atrium. Well, okay, so the filling, it takes time to fill the right atrium. Where is it filled from? Superior vena cava, inferior vena cava, and coronary sinus. So it's increased right atrial pressure due to filling against a closed tricuspid valve. The tricuspid valve must be closed. And lastly, Y descent, right atrium. At Y descent, the right atrium empties its content inside of the right ventricle, and it will be prominent in pericarditis. And I want to tell you something about pericarditis here, guys. First of all, pericarditis, just imagine this as a Y. Pericarditis is written with a Y, so it's Y descent, okay? But why it is in constrictive pericarditis, it's a prominent. Imagine this, guys. In constrictive pericarditis, the blood is not able to move normally, okay? So it's not being able to go to the right atrium and right ventricle normally, because they have this form of restrictive heart disease. It's preventing the right atrium and the right ventricle to perceive normally the blood they should perceive. So what happens is that they will not be able to empty normally, and if when they will not be able to empty normally, there will be an increase in the jugular venous distension. So the what will happen is that you will have, see this Y descent? Y descent represents what? Right atrium emptying in the right ventricle. So if you have constrictive pericarditis, what will happen to this? Excellent. It will be something like this. Okay, guys. So this is there is also one more thing in case of cardiac tamponade. See this Y wave? Forget about it. It's flat. Why? Because in case of cardiac tamponade, we have a blood around the heart, all over the heart. So all chambers of the heart will have similar blood pressure. Yeah? And since all of them have the similar blood pressure, nothing is moving anywhere. So they will be totally absent. There is no emptying anywhere in case of tamponade, because in case of tamponade, all of the heart chambers are becoming equalized with each other. Okay, guys? Okay, so next thing, here we are going to speak about some heart sounds. So here it becomes more interesting for most students, because now we are going to describe heart sounds. Yep. So, guys, quick poll. Heart sounds versus pathology. Right patho or heart? Okay, 5 votes I need at least. That's one. Heart versus patho. 2 for heart. 3 for heart. 4 for heart. One more. Okay, I choose heart as well. That's 5. So we have a pressure volume loops and valvular disease. So, okay, what is the idea here? First of all, why in first aid they only mention the mitral and the aortic stenosis graphs? Why they do not mention the tricuspid and the pulmonic valves? Here is the idea, guys. Remember when I told you I wrote that thing about the heart sounds, and I told you that the left side is exactly the right side? So aortic stenosis graph is exactly like pulmonic stenosis. Mitral regurg is exactly like a tricuspid regurg. Aortic regurg is exactly like pulmonic regurg. Mitral stenosis is exactly as a tricuspid stenosis. So if they give you a graph of the right heart, just take the analog valve of the left heart and it will be the same graph. Write a note about that. That will help you significantly. In this, a few questions will be like this. It can be like super tricky question if they do that for you. Okay, so you remember in case of aortic stenosis with an O, it's a problem with opening the valve. If the valve is not opening correctly, normally I have questions for you guys. I hope you are ready. So if you see this graph here, let me put this here, let me put this there. Okay, so guys, I will write 1, 2, 3, and 4. Where does the aortic valve open normally? Forget about the pathology here. Good, it's 2. It's 2. What about where does the between which two of the numbers I draw here, which two numbers we have isovolumetric, all valves are closed. Where we have all valve closed? Between which two? Yes, between 1 and 2 and also 3 and 4. Excellent. Can someone tell me please, where does the aortic valve close? Yes, it's 3. Excellent, guys. Can someone tell me please, where does the mitral valve close? Excellent, excellent everybody. Okay, so now let's go to the pathological one. So here is 1, here comes, so it's like, so it's somewhere right here, the actual ejection. Like this, and this goes like this. Can someone tell me what will happen to the stroke volume? Up or down? Good, it's down. Can someone tell me please what happens to the yeah. Yeah, good. So what happens to the left ventricular and diastolic pressure? Left ventricular and diastolic pressure. Good. What about what happens to the volume? What happens to the end systolic volume? End systolic volume increased. Good. And diastolic volume? Same, exactly. Good job, guys. So this explains for you what everything is moving and how everything is going. They will give you a graph like this. You need to think with yourself. Well, this looks like it was pretty difficult for the aortic valve to open. Yes, since it was really difficult for the aortic valve to open, aortic valve open, so that must be aortic stenosis because it's a problem with the opening. Okay, so that makes sense, and it has shut it down really quick because the valve was really stiff, and that helped you to like get it correct on the exam. That's the main idea of it. Okay, let's go back here. So you can see here a graph of aortic stenosis. We just explained it. And here we have another graph that will explain it in a second. So just for now, stick with this. What is this? It's what we have just explained here. Remember about these guys? Like the different pressure at different chambers? It's exactly the same thing. So let's take a look at it here. So in case of aortic stenosis, the left ventricular pressure will be higher, obviously, because they are trying to contract against like a really stiffened valve. Yeah, so the left ventricular pressure will be higher. So which one of these three graphs represents? So you remember the pink one represented what? It was the aorta. This one with the diastolic being 10 and the systolic being really high, that was the left ventricle. So since it is the left ventricle, you can see it like shooting up all the way until here, and then it goes down, up, down. So, but notice here, the left ventricular pressure is much higher than the aortic pressure, while in reality, like it was in the heart, it was 120/10, and in the aorta, it was 120/80. So the systolic should be the same, but the systolic in case of aortic stenosis in the left ventricle is much higher than the aorta. So this difference here tells you what? It tells you that it is for the left ventricle, it's much harder to open the valve. So okay, the end systolic volume, what what will happen to the end systolic volume? You told me it will increase. So what about the end diastolic volume? It will not change, you said that, and the stroke volume, you said that it will decrease as well. So the aortic stenosis, there is increased afterload, obviously, resistance against the heart pushing. So there will be ventricular hypertrophy and decrease in the ventricular compliance, obviously, if there is decrease in the ventricular compliance, but that takes time, guys. So after many years, the patient will have increased end diastolic pressure and for giving end diastolic volume. So the volume will be kind of the same, but the pressure will be much higher. Why? Because the walls of the ventricle has become more stiffened. Why? Because the pressure against the ventricle was more higher. Okay, so I will give you a trick to know a valve, is it a regurg or is it stenosis. Remember, guys, when I told you about a regurg, it was a problem with closing the valve. Since it's a problem with closing a valve, you will never have a flat line. So take a look at mitral and aortic regurg. Can you see any flat line in this ball, basically? There is no flat line, like between one valve and another. Why? Because always there is movement in or out of the heart, you know? Because you have this regurg. So let's take it a little bit more deeply. It's kind of hard to know where exactly each valve open and closing it, and mostly they won't ask you about this in case of regurg. They will ask it in stenosis, but mostly not in regurg because it's kind of difficult to know exactly where it happened. But overall, there is a few questions that we can ask ourselves. For example, Here they write no true isovolumetric phase. Why? We just said there is always a valve that is leaking and moving blood in or out. That will always lead to different left ventricular volume and left ventricular pressure. So there will also be a decrease in the end systolic volume. So that decrease in the end systolic volume is due to the decrease in the resistance. So there is end systolic volume is it's here. So why it has changed? Because there is less resistance. Why there is less resistance in case of mitral regurg? Because the moment you get it out, it goes back. Why? Because the left ventricle is not able to handle it. It just like the moment it goes to the left ventricle, he wants to close, he cannot. The blood comes back, so it becomes round. Okay, that's why you never get a flat line. The main thing to know is that you never get a flat line. So the decrease in the end systolic volume happens due to decreased resistance and increased regurgitation into the left atrium during systole. So this is the left ventricle, guys. Yes. So at this point, you are supposed to close what? You are supposed to close which valve at this point? Exactly this point. Someone write me. And which valve is open at that point? Well, normally, not in this pathological state. Normally, which valve is supposed to open at that area here? Well, here. Yeah, here. None. Exactly. None. It's the isovolumetric relaxation. That's how they trick the student. So during isovolumetric relaxation and isovolumetric contraction, the valve is supposed to be closed. But in regurg, they cannot close. That's why it's always twisted. See, guys, it's twisted here, it's twisted there. So none. It's supposed to be none. So decreased end systolic volume due to decreased resistance and increased regurg into the left atrium during systole. So in that case, you will have much less end systolic volume. Also, we have end diastolic volume is much more increased. So what is the end diastolic volume? It's here. Why it would lead to basically increased end diastolic volume? Well, look, guys, it's kind of like a dilemma. So there is an increase in the end diastolic volume. Why? Because the left atrium volume has increased. Why it has increased, the left atrial and the pressure volume? Because there was increased ventricular filling. Why there is increased ventricular filling? Why there is increased ventricular filling? Because there is increased left atrial volume. Why there is increased left atrial volume? Because of the regurg that leads to increased ventricular filling. So they keep causing each other, type of thing. And the last thing, what happens to the stroke volume? It will be massive. It will go out. But here's the thing. Even during the contraction, keep in mind that some blood will go back to the left atrium. So you can see during isovolumetric contraction, which is the period where suppose all valves should be closed, this represents the blood leaking to the left atrium. Okay, guys, and this moment is supposed like to open the aortic. It's not opening fully, as you can see. Like even when it opens, it is still leaking inside of the left atrium. Okay. Aortic regurg, kind of the similar graph. You will never find isovolumetric phase. And in case of aortic regurg, your end diastolic volume obviously will be higher because you are getting more blood from where? From the aorta. The stroke volume will also be higher. Why? Because the preload is much more higher. So let's take a look at the next graph. So here we have the mitral regurg, and you can see it's not affecting the pink graph, which represents the aorta. It's not affecting the ventricles, left ventricle graph, but it is affecting what? It is affecting the one related to the left atrial pressure. So the left atrial pressure, if you remember the V wave, it was V for Villing, yeah? In case of mitral regurg, we have a lot of villing of the left atrium. So the V wave will be skyrocketing, as you can see. In case of aortic regurg, well, it's simple. If you speak about aortic regurg, the first moment you'll be like, oh no, this is normal. It's not. Notice here, guys. This in the pink, the systolic blood pressure is 120, that's correct. But in the aorta, it's 120 over 80, not 50. If you say it's 120 over 50, that means the pulse pressure is ridiculously high. If the pulse pressure is ridiculously high, which ridiculously high means more than 60, make a note about this. If it is more than 60, that means that there is some form of, well, leakage backward. So that happens due to aortic regurg. Keep in mind, please, that in case of aortic regurg, the systolic blood pressure is normal. The diastolic is the one that is low. Okay, so these stenosis. So mitral stenosis is actually also quite interesting. Let's speak about mitral stenosis a bit. So in case of mitral stenosis, let me ask you a question, guys. I love asking you a question. What happened to left atrial pressure in case of mitral stenosis? Left atrial pressure. Okay, it's increased. Okay, if the left atrium pressure is always increased, the blood cannot move to the left ventricle. That is correct. And what will happen to the filling of the left ventricle? Filling of left ventricle in case of mitral stenosis, it will be higher or lower? Decreased, obviously. And if that is true, what will happen to the end diastolic volume? Okay, what about the end systolic volume? Excellent. No, also decreased. Both of them are decreased, guys, because the volume overall is decreased, okay, in the circulation. I will explain more about it in a second. Last thing, what will happen to the stroke volume if you have less preload, such as in this case? Let's see. Oh, I cannot go down. Okay, low. Excellent. Okay, so they write for us here that in case of mitral stenosis, you have left atrium pressure will be high. So the left atrium pressure will be skyrocketing. And you said that, and it makes sense. So here, left atrial pressure, oh, 100. That does not look bad. It's super bad. Normal was a 12. It's 100. This is ridiculous. It should not be here. So if you take a look here, sorry, I apologize. I did some mistake here. Let me go back and re-explain what I just said. So in case of left ventricular pressure here is written. It's not left atrial pressure. If left atrial pressure was 100, the person will be dead. So this is left ventricular pressure they are writing. So if in case of left ventricular pressure, why it's reduced in this case, the systolic one at least, because you have less preload inside of the heart. So the distension of the heart will be less. So the Starling mechanism will be less. So the contraction will be less. So if you take a look at this guy, the filling of the heart during diastole is less. So the end diastolic volume is less. The end systolic volume after the short contraction is also less. Everything is less. Okay, if you take a look at this one, we don't really care about the aorta or the left ventricular pressure here because they can be kind of normal. Maybe the left ventricle will be reduced even. Why? Because you have less filling. As you can see, it's near 0. It should not. It used to be 10, not near 0. But the main one to know is the left atrial pressure. The left atrial pressure is super high. It's like here maybe 30 or 25 even. Normally it should be. It used to be 12, not this much. I hope that made sense. I know this graph is kind of difficult. Just after we finish, try to go over it one more time, like these two, and you will master it, guys. It's not that difficult. But this page, yeah, I agree with you. It's kind of hard, but this one is not that bad. Okay, now let's speak about the next topic, splitting of the S's. So we have S1, S2, all of that good stuff. So I will give you a short explanation about it, take a break, come back, explain this, and show you each heart sounds. And for tomorrow, actually, guys, I have a home task for you. I will give you different heart sounds that you will listen to. And tomorrow during our class, I will play some hard sounds for you, and you must identify it as cases. So that is important. Okay, so splitting of S2. So normally there is this physiological splitting. What is physiological splitting? Well, in our heart, if you remember, we had the S1 and we had the S2. This means something, forget about this. We now care only about the S2. So what happens during the S2? Two valve closes, which are the aortic and pulmonic. The period between aortic closure and pulmonic closure, there is a little period between them, you know. This one happens faster than this one. Why? Because of the amount of the blood, and also because, like, you know, when you inspire, like, and expire. So when you inspire, you get more blood to where? To your right heart. A lot of students be like, okay, I know that I memorized this. More blood when I inspire to the right heart, more blood when I expire to my left heart. But why? Why is this the case? Well, let's do this, guys. Let's inspire. When you inspired, what has happened? You have compressed your inferior and superior vena cava. So whatever blood in them has been pushed where? So exactly, when you inspired, all of the blood inside of them has been pushed inside of your right heart. That's why the sound become more delayed, you know, guys, because it has to accommodate to that a little bit of kick of blood you have pushed in. So let's take a look here. We have physiological splitting. They write inspiration lead to what? First thing first. Inspiration, a drop in the intrathoracic pressure. What is this intrathoracic pressure? So there is an area between your lung and your chest. If you say that this is your chest cavity and this is your lung inside of it, okay? There is an area between the two. Normally, the pressure in it is -5. Like, it helps you to keep the gradient. The normal gradient is about -5. What does that mean? It means that always your chest, well, first of all, why it's -5, we need to understand. So this is your lung, and this is your chest wall. Guys, you must know this. Without this, you will not understand the most of the concepts in respiratory system. So this is your chest wall. Chest wall always want to what? You have your chest wall and you have your lung. Lung always want to collapse, okay? If you take a lung, put it outside, it always want to collapse on itself. So what keeps your alveoli open? What keeps your lung open? It is your intrathoracic pressure. So, okay, it looks like lung is negative. It's always negative pressure. So you need a positive pressure to compensate for it. So what is this? It's the chest wall. Chest wall always want to collapse, but outward, not inward. Guys, go to the morgue, open a dead person. The moment you open his chest, it will open for you. It's like magic. So it opens for you. Why? Because the chest is more prone, the arch of the chest are more prone. The moment you cut it, it will just open up. So that is collapsing to the outside. Collapsing to the outside with the collapsing to the inside will lead to a gradient that is -5. So that's why you always have your alveoli open and not collapsing. Okay? So, okay, let's now speak about this. So when you deeply inspire this -5, what happens to it? It will drop even more. When it drops even more, so this is -5, so now it becomes, let's say, -15. If it's -15, there is a beautiful inferior vena cava going inside of your chest. Yes? If it becomes -15, it will literally suck the blood from the inferior vena cava, like from the abdomen and from the other organs inside of the chest. Yeah? It will suck it from the abdomen to the chest. And when it does this, it will go to where? To your right atrium, right ventricle, to your lung. So, they write. Drop in the intrathoracic pressure, lead to increase in the venous return, lead to increase in the right ventricular filling, obviously. More right ventricular stroke volume. More right ventricle ejection time. That leads to delay in the closure of the pulmonic valve. And that leads to the split, physiological split. Okay, that sounds good. Well, many students ask me this. How can I differentiate between a split and an S3? Fair question, because both of them sounds kind of like this. It's about the breathing guide. So look, If it changes with the breathing, this is not an S3. S3 never changes with the breathing. If it changes with the breathing, it's splitting. So the first thing to check if the sound is changes with the breathing. I have no idea how people can listen to someone's chest for 5 seconds and know that he's normal. No, it takes more than that, guys. Okay, so okay, for now, let's take our break and come back and explain the rest of it. I hope our new members are enjoying the class, and we'll keep going after the break. So break for 10 minutes. See you guys at 8. And you see it?
Yes.
Excellent. Okay, so we have the following. We have the physiological splitting. We have explained how it occurs. It was not a direct mechanism. It was like, you saw what happened. The intrathoracic pressure has dropped significantly. That led to the suction motion from the inferior and superior vena cava, which brought the blood from different cavities inside of your body back to your chest. That increased the filling of your right ventricle, which led to the right ventricular stroke volume being much higher, and that led to right ventricle ejection time taking longer period of time. And that delayed the closure of the pulmonic valve. So the next time someone will tell you, during inspiration I have increased blood coming back to the heart. Like, yeah, it's a long process. So there will be a decreased pulmonary impedance, which is going to lead to an increased capacity of the pulmonary circulation. So also it occurs during inspiration, which contributes to the delay of closure of pulmonic valve. So what does it mean, decrease of pulmonic impedance? Guys, imagine this with me. If your alveole is like this, and your vessel is like this, if you take deep inspiration, your alveole will become bigger, become like this. So it will squeeze down the blood supply a little bit, yeah? So it will push back the blood supply a little bit. That will delay the movement of the blood from your right ventricle to your lung. If that is true, there will decrease in the impedance of the pulmonary of the lung, which will lead to delayed movement of the blood through the pulmonic valve, which leads to the delay during the inspiration. So 2 mechanisms, guys, not 1. Okay, now let's speak about the pathological stuff. All of what I just said, that was normal. So now let's make it abnormal. To be truthful with you guys, from this page, they always ask the same question. It's about the fixed splitting. But for the sake of completeness, I will explain all of them. But the most high yield one between all of these guys are the fixed splitting. This is the one that you must know because they do ask about it. So the wide splitting, it's seen in condition that delays the right ventricular emptying. So what does it mean, wide splitting? Well, during inspiration, there is ridiculously long period of splitting, yeah? Well, what about during expiration? Well, E is for expiration. Expiration, still there is splitting, but it becomes much worse with inspiration. Wait a second, are you telling me that there is splitting during expiration and inspiration? Yes, but it becomes even worse in inspiration. This is different from fixed splitting, in which it is constant, it's equal during inspiration and expiration. And here is the thing. So they write, it's seen in condition that delays the right ventricular emptying. For example, pulmonic stenosis or right bundle branch block. Why right bundle branch block? Because in right bundle branch block, your right ventricle contraction will be poor. If that is true, you can imagine what happens. It basically will be really difficult for it to contract. The next one causes delayed pulmonic sound, especially on inspiration. So there is during inspiration, we spoke about the 2 mechanisms that delays the heart sound due to more time requiring for the transmission of the blood from the from the right ventricle to the lung. An exaggeration of normal splitting. So you have a normal splitting, but in wide splitting, it's just like, yeah, just louder. Worse. Why? Because of right heart problem. Why I told you right heart problem? See these guys, the pulmonic stenosis and right bundle branch block? Take the exact opposite for these. I mean by opposite, exactly what happens in the other portion of your heart, which is your left heart, which will be like aortic stenosis and left bundle branch block. They will lead to the paradoxical splitting, okay? So I'm leaving this for the last because I told you they keep asking about it. So paradoxical splitting, it's herding condition that delays aortic valve closure. Like for example, in case of aortic stenosis and left bundle branch block. So in case of aortic stenosis and left bundle branch block, there will be what? Paradoxical. What does it mean paradoxical? The splitting is occurring at expiration, which means it's in the left heart, not the right heart. This is abnormal. This is due to the delay of emptying of your left heart. Why would your left heart delays its emptying? It could be due to an aortic stenosis or a left bundle branch block. Normal order of semilunar valve closure is reversed so that the P2 sound occurs before the delayed A2 sound. So the P2 sounds normally should occur after the A1 sound. But what happens in this condition that it's reversed? The A2 sound is occurring too much later. Why? Because the outflow tract is obstructed or the left ventricle is not willing to contract normally. That's why the A2 is happening a little bit later because it's not able to close at time. So on inspiration, the B2 closes later. So if you expire, what happens? It becomes, the sound become normal. It becomes back to normal. Why? Because when you inspire, see your pulmonic, it becomes delayed, which is like physiological splitting. So when it becomes delayed, it becomes closer to the A2. And when it becomes closer to the A2, that's it. It just like becomes like normal, S1, S2. So normal order of semilunar valve closure is reversed so that the B2 occurs before the delayed A2. On inspiration, the B2 closes later and moves closer to the A2, which is paradoxical, eliminating the split. So that's what just happened. Like I told you, you inspire, the B2 goes near the A2 and the sound disappears, basically. So on inspiration, yeah, we spoke about this. On expiration, what happens? On expiration, there is more blood in your left heart. So the split can be heard opposite to the physiological splitting. So in expiration, normally, in physiological splitting, you should not hear it. But in case of paradoxical splitting, you only hear it during the expiration. Okay, so again, right splitting, right heart stuff, left splitting, paradoxical splitting is the left heart stuff. Right heart, left heart. Right heart, left heart. Okay. Last thing is fixed splitting, which actually this is like, if you want to memorize one thing from this page, please memorize this. It's the only thing they ask. So it's heard in conditions such as ASD, atrial septal defect, which leads to shunts. Well, the pressure, where it is higher inside of your heart, is it the left atrium or the right atrium? Correct, it's left atrium. So that leads to left to right shunt. That leads to the right atrium and right ventricular volume to be much higher. If that is true, there will be more flow through the what? The pulmonic valve. Is it more during inspiration or the expiration, the flow? Both, it's equal. So during inspiration or expiration, always there is movement from the left atrium to the right atrium. If that is true, there will be constant delay in the pulmonic valve closure, independent of the respiration. Because it's practically independent. The left to right shunt is always happening during systole or diastole. So you will always have the splitting regardless of the fact if you are inspiring or expiring. If you had to know one thing, please know about fixed splitting, its relationship with ASD and its relationship with Down syndrome. Why Down syndrome? Because ASD can be in Down syndrome. Okay, so now we have these heart sounds. Okay, so last option, guys. Should we finish heart sounds or should we go to pathology? I want 4 votes. Heart sounds or pathology? 1 for heart, Batho. Okay, one more for batho and we will go to batho. Okay, batho it is. I know guys, I actually prefer that since the material is a lot and you must review it before moving forward. Because if you don't review it, it's basically too much, you know? I know that it's only 3 pages we did. But this section of first aid, especially the physiology of cardiovascular system, the physiology of the respiratory system, these type of topics, they require you to sit a little bit and digest that info. It's not one of the easy topics. Okay, so previous time we spoke about different types of necrosis. Now we are going to speak about ischemia. So ischemia is decrease of oxygenation and blood supply to meet the demand. If the organ tells you I want if the organ tells you I want 10 oxygen and you only can give him 5, he will be sad. So he will be so sad he will commit suicide. He will take a gun and shoot himself. So you don't want that. So how can you, and that shooting himself is basically like hypoxia leading to ischemia. You don't want ischemia. You want to keep him happy by two ways. First of all, you need to increase the supply, if you can. So if you can increase the supply, that will be awesome. If you can give him 10 for 10, he will be happy. That will be great. But if it's not possible, tell him, okay, try to decrease your demand. But he's like, I'm working so much, I cannot decrease my demand. Well, work less. Don't work for 10 hours a day. Work for 6 hours a day. And I will pay you the same. But I want 6 for them, not 5. Well, I don't care. 5 is better than nothing. So you will be, the tissue will still be hypoxic, but will not dead. And that's important. Why? Because what I just told you, this story, is basically how we treat a myocardial ischemia. If we imagine we have a myocardial tissue, okay? We know that sometimes we give beta blockers for the patient. Why do we give the beta blockers? We reduce the heart rate. Why we want to reduce the heart rate? We reduce the contractility. Actually, the main reason we do that is to decrease the ischemia. To decrease the demand of the heart of oxygen. When you decrease the demand of the heart for oxygen, you're still supplying him with the same amount of oxygen. But the demand is reduced, so the ischemia is less. Okay, let's take a look. So ischemia is an inadequate blood supply to meet the demand. The mechanism include decreased arterial perfusion, for example, in cases of atherosclerosis. Also, we have a different type of ischemia. We call it like red ischemia or hemorrhagic ischemia. It can happen in cases of decreased venous drainage. Decreased venous drainage can be in cases of testicular torsion and Budd-Chiari syndrome. Let's take a look what does testicular torsion mean. Testicular torsion, if you have the testicles like this, you have arteries and veins on the testicles. You are obligated to know where the arteries are located and where the veins are located. The arteries are located in the middles, and the veins are basically a network around the arteries. So they are okay, that was a bad idea. Okay, so this is an artery, and the veins are just like a big network all around the artery. Okay, so you can imagine, guys, in case of a torsion of the testicle, it has twisted around itself. What will happen? The arteries is pretty thick. You can imagine if you hold an artery versus a vein in your hand. Vein will collapse, artery will not. It's pretty thick. So if you rotate the testicles around itself, what will happen? The veins will be congested on each other, yeah? Because you are compressing them. But the artery is in the middle. He doesn't really care. So blood will be continuously flowing through the testicle, but it will not be able to exit. So a lot of blood in the testicle, it's not able to exit. That leads to testicular infarction, basically. So testicular torsion. Yes, so you can see the twisting around itself, that leading to ischemia, and then it can lead to infarction. At a gross examination, if you take a look at the testicle and you actually cut it, when you look inside of it, what you are going to see? Exactly this bunch of blood. Why it's bloody, bloody, bloody? Oh, see, it's black even. It's like blood. So why it's like this? Because what happened, a lot of the blood has went inside, but it could not leave outside. So the blood, you can imagine, this is the testicle. So this is like the artery coming inside of it. That's here. And the veins are going outside of it. And when it was twisted, the veins were occluded, but the arteries was intact. So continuous blood inside of the testicle, but it's not leaving out, led to accumulation of the blood inside of the testicles. You can think how painful that must have been for the patient. And yeah, that leads to basically hemorrhagic ischemia, as you can imagine, due to congestion of the veins. It also happens in one other disease, Budd-Chiari syndrome. If we imagine that this is the liver has this falciform ligament here, and also it has one more thing. It has here, it connects to what? To the hepatic vein. The hepatic vein connects to what? To the inferior vena cava. I'm bad at the drawing, guys. So anyway, here we have the portal vein. Portal vein comes from the GI. In case of a syndrome called Budd-Chiari syndrome, the main idea that there is an occlusion of the hepatic vein at this portion. Why there is an occlusion of the hepatic vein at this portion? Most likely, it's due to a hypercoagulable state. What can lead to hypercoagulable state leading to occlusion of the hepatic vein? The first reason is OCP, oral contraceptive pills. Why? Because estrogen leads to hypercoagulable state leads to this. What else? Well, another cause of hypercoagulable state is polycythemia. Do you remember, guys, when we spoke about the viscosity? Yes. So when you increase the viscosity, you have basically increased viscosity of the blood, which promote your risk of thrombosis. So what is the most common cause of this syndrome? By the way, occlusion of the hepatic vein leading to this syndrome, we call it Budd-Chiari syndrome. So this Budd-Chiari syndrome is most likely due to hypercoagulable state or polycythemia, which can increase the viscosity of the blood. Polycythemia is a condition that is secondary to the JAK-STAT mutation that we will speak about. This is in basically we'll speak about when we speak about the tumors and how they occur, but it's due to hyperproliferation of the stem cells of the blood. Anyway, what else can lead to hypercoagulable state? Cancers. Which one specifically? Mostly pancreatic cancer, but any visceral cancer can lead to hypercoagulable state. So, okay, this got occluded. So what is the big of a deal? Well, the blood is flowing here. It's going inside. But it's not leaving. So the blood will accumulate inside of the what? Inside of the liver. So you can get liver failure, but in addition, not only liver problem, Budd-Chiari syndrome, not only liver problem, but it can lead to symptoms like symptoms exactly like portal hypertension in addition to an enlarged liver. So if they give you a condition about portal hypertension, check the size of the liver. If it was ridiculously big and tender, it was painful, think about Budd-Chiari syndrome. And remember it mostly in case of polycythemia. Yeah, you can see a lot of blood inside of this liver. This is Budd-Chiari syndrome. Okay, good. So the next, here we have like decreased venous drainage, testicular torsion, Budd-Chiari syndrome. Also, ischemia can be due to shock. Shock is a simple way of telling you hypotension. A lot of causes there is of shock. We have cardiogenic, anaphylactic, distributive, neurogenic. We'll speak about all of them when we reach them. But mainly, the main idea is decreased blood pressure, which lead to decreased perfusion, which lead to ischemia. Region most vulnerable to hypoxia and ischemia and subsequent infarction include the following. Now I'm going to teach you guys a concept called watershed area. What is watershed area? Guys, when we have two arteries supplying the same area, it's not a good thing. So if we have this territory here, and this guy say, okay, I will fix it, and this guy say, no, I will fix it, I will supply it. Well, everybody will supply his area, okay? But there will be a little area in the middle. See this area? It's a watershed area. It will not be supplied by either of them. So the moment there is any form of hypoperfusion to an organ, the first area to be screwed and dead will be that area in the middle. That area we call it watershed area, okay? So it's watershed area. Okay, so let's take a look at it. In case of the brain, we have two main watershed areas. So if you remember of the brain, when you look at the brain, let's imagine that we have a section across the brain, section across the brain like this. And I hope you remember that you had the cycle of Willis, and you had like this, this is schematic. You have the ACA, anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. It's just a schematic, nothing anatomical. So let's imagine that someone had massive hypotension in his body, like he had really bad hemorrhage. Which areas are most likely to be destroyed? Well, the watershed areas, which are between the ACA and the MCA, and between the MCA and the BCA. Yeah? So, okay, how do they look like in real patient, you know? So I want to show you guys how they look like. In addition, I want to tell you the symptoms the patient will have, because it's super important to know the symptoms, and it's kind of cool actually. Okay, so you can see here, it's the area that is between the ACA and the MCA, and between the MCA and the BCA. Let me send you this picture, guys. Okay, so the next thing here, we have the brain. We said about the watershed area. Look what they write here, guys. Watershed area, border zones. They receive a blood supply from most distal branches of two arteries with limited collateral vascularity, which means, like I told you guys, about this two territory type of thing. So this guy tells, I got it, and this one tell you, I got it. But in reality, yeah, they got everything except this freaking point that everybody is fighting about, but it's the only one who's actually getting all of the harm. So yeah, these areas are susceptible to ischemia from hypoperfusion, which can be due to ischemia or shock. Okay, let's say someone got this area destroyed. What will he happen? Guys, know this. All of his proximal muscles will be destroyed. So he will get paralysis, but it's one that is interesting. We call it like a man in a battle. So his head will be moving okay, his bones and soles will be moving okay, but nothing else. So his legs cannot move, his hands cannot move, his neck cannot move. The only thing that can move is his face muscles, hands, bones, and soles. That's it. Yeah, man in a barrel. So you can imagine like he's inside of a barrel, his hands are out and his legs are out. And yeah, it's kind of cool. So next one is the heart. Well, our lovely organ. So in the heart, the area that is considered a watershed area is the subendocardium. Why? So many students confuse this. They think that the heart supply is from the inside. Well, guys, do you remember where the coronary artery come out from? They come from the aorta. After they come out from the aorta, where do they go to? Well, they go around the heart. They go around the heart like this. Okay, and you know, they give all of their branches. Anyway, so we have this heart is getting the blood supply from the outside. So just let's imagine like this is a section of the heart for a second, something like this. Okay, so the coronary arteries are located here. Okay, it's the most outside area. So if they want to supply the heart, they must penetrate the myocardium like this, all the way until here. So guys, this portion of the heart, which I'm going to make in green, this one, until the end, we call this portion subendocardial area. Okay, subendocardial area. So this subendocardial area is not supplied. There's a plenty of blood here, plenty of blood, but it's not supplied by it. It's supplied by the coronary artery from the outside to the inside. So if there is any form of hypoperfusion to this coronary artery by any way, the first portion to be destroyed inside of your heart will be the subendocardial space. I hope it makes sense. Okay. So the next thing we are going to speak about, let's take a look. Yeah, so the subendocardial, and we'll speak about a specific type of MI ST segment depression, myocardial infarction, not elevation but depression. Okay, the next one will be the kidney. In the kidney, the two areas that are mostly susceptible for ischemia are the ones that are the most metabolically active, which include, first of all, the straight segment of the proximal tubule, which are located in the medulla, and also the thick ascending.
Yeah.
Yes.
Some students are saying that they can't hear you well. Maybe you have an internet issues.
Just a second, let me check. Hello, can you hear me? Can you hear me, guys?
Yeah, it's better now.
It's better? When did you stop hearing me?
No, we were hearing you all the time, but like the sound wasn't.
I see. Okay, sorry guys. Okay, so speaking now about the kidney, so the portion of the kidney that are highly metabolically active are the ones that will be mostly affected. So this includes the proximal tubule and the thick ascending limb of Henle. Why? Because they are the areas where most of the function of the tubules occur. Proximal tubule practically takes the most function of your tubules. The same with the thick ascending limb of Henle, she does a lot as well. We'll speak about it when we do renal. Next, the liver, the third zone. What is these zones? Basically, your hepatic triad. Let me show you this, guys. So inside of the liver, there is something called a triad. Inside of the triad, there is the three zones. So you can see this is the liver triad and the portal triad. You can see it here. And there is the lobule. So this is the lobule. Here you have the triad in the lobule. And here you have the central vein, which goes to the hepatic vein. And here we have the portal vein. So the portal goes to the hepatic, yeah? And according to the way, we have zone 1, zone 2, zone 3. So the zone 1 will have the most amount of oxygenated blood, and the zone 3 will have the least amount of oxygenated blood. You must know this. Okay, so let's go back to this. So we have colon. In the colon, it's the splenic flexure. A graphene point. It's basically where two vessels connect with each other. Like it is near the splenic flexure. You can think it's where the SMA and the IMA connect with each other. And rectosigmoid, it's where the IMA and what else? The IMA and the superior rectal connect with each other. Okay, last thing down there in the brain, they write neurons most vulnerable to hypoxic ischemia, hypoxic insult include Purkinje fiber of the cerebellum that will lead to ataxia, and pyramidal cells of the hippocampus and neocortex. Okay, the zones 3, 5, and 6. Actually, we will speak about this. The Purkinje cells in the cerebellum that leads to ataxia. The hippocampus can lead to anterograde amnesia, not retrograde, only anterograde. Okay. And neocortex can lead to amnesia itself, like retrograde amnesia. So types of the infarction. We have the red and the pale. We spoke about the red one. It occurs in case of venous occlusion and tissues with multiple blood supply, like the liver. I showed you this. It could be in the lung, like you can see in this page. And you can see why the lung actually, because it has both sublimate from the pulmonary trunk and also the bronchial arteries. So two blood supplies. In the intestine as well, and in the testicles, as I showed you. And with reperfusion injury. For example, like someone had, let's say MI, and he was reperfused. And when he got reperfused, there is a lot of free radicals. And these free radicals go rapidly inside of the organ and they destroy the whole area. So yeah, that can lead to red infarction as well. The bale infarction, on the other hand, it occurs in solid organs with a single end arterial supply, blood supply. For example, the heart and the kidney. Okay, so this is the simple one. It just like has the switch shape area and it will be bale. So the free radical injury, the next topic. Guys, first of all, I want you to know what is a free radical. Well, if we imagine that we have one atom, okay? This atom has a nucleus. Around the nucleus, it has 2 electrons. Let's say that, and then it has 8. You know this from school. And then the next one, let's say it only has 1. See this one? It can be donated super easy. Thus, this is a free radical. He just wanna connect to anything to destroy it. So, free radicals, that's what they mean. So, free radical damage via the membrane lipid peroxidation. And yeah, so there is a lot of lipids in the walls. Maybe you remember that the cell wall is consistent of a lot of proteins, lipid, and cholesterol. So in case of free radical injury, it actually leads to lipid peroxidation. Also, it can lead to protein modification, and the worst of all, DNA breakage. Okay, so initiated via radiation exposure, like cancer therapy. Wait a second, so they are writing that cancer therapy can lead to cancer? Exactly. And metabolism of the drugs. For example, in the phase 1. What is this phase 1? We'll speak about it in pharmacology. There is 2 phases for metabolization of any drug, phase 1 and phase 2. These 2 processes occurs in the cytochrome B450 inside of your liver. We'll speak about it more deeply when we reach it. Also, redox reaction, which we'll speak about it deeply in biochem. Nitric oxide in case of inflammation. Remember, nitric oxide comes from which amino acid? They keep asking about this one. Correct, it's arginine. And where do we make nitric oxide? Correct, it's endothelial cells. And then we have a transition metals, which we'll speak about, like this Fenton reaction, and like they can convert iron into a free radical or copper into a free radical. Also, white blood cells, like for example the neutrophils and the macrophages. Okay, so yeah, and in case of the oxidative burst, this oxidative burst basically is a natural way inside of your body to create free radicals, which will help you kill specific bacteria, especially catalase positive bacteria, which we'll speak about, like Staph aureus. Free radicals can be eliminated by scavenging enzymes like catalase, superoxide dismutase, and glutathione peroxidase. Well, actually, we want antioxidants. Antioxidants are not bad in our body. They prevent mutations. But in the same time, we need to keep in mind that our body actually makes some free radicals to save our lives against catalase positive infections. So yeah, it's we need to know that as well. Not all free radicals are super deadly and they will totally kill you. So spontaneous decay can also lead to spontaneous decay. What does that mean? If you have a free radicals, they can like simply just bind to each other or bind to something near them and they become neutralized, and that's it. Spontaneous decay. And the last way to get rid of free radicals is antioxidant. Sorry, not the last way, but one of the ways is antioxidant with vitamin A, C, and E. You must know this. If you forget about it, I used to remember it. You remember the ACE inhibitor? I used to tell myself, okay, it's ACE. Free radicals, antioxidant are ACE. Vitamin A, C, and E. And certain metals carrier proteins, like the transferrin in case of iron, and ceruloplasmin in case of copper. Okay, so we have some examples. Oxygen toxicity. So why oxygen toxicity occur? Guys, maybe you know about the neonatal respiratory distress syndrome. It's a syndrome in which the baby does not have enough enough maturation of his lung. So in addition to giving him the steroid, we do give him a lot of oxygenation. And when you give that oxygen, the patient can have one of this oxygen toxicity syndrome. So he can have retinopathy of prematurity. It leads to abnormal vascularization, and sadly, it's irreversible. The patient will go blind for life. And the next one is the bronchopulmonary dysplasia. In this case, the patient will have wheezing. It's due also to the same thing I told you about, the NRDS, neonatal respiratory distress syndrome. The last thing is reperfusion if injury after a thrombolytic therapy. So if an organ is poorly perfused due to like an emboli occluding the vessel, you open the vessel and the blood will go back flowing to that area. A lot of free radicals will be accumulating and suddenly will go there, and that will lead to damage. The next example is a drug and chemical toxicity. For example, in case of acetaminophen overdose. Guys, do not be tricked. Acetaminophen is not an NSAID. It works directly on your CNS. So acetaminophen overdose can lead to hepatotoxicity. And also we have, oh, this is important, carbon tetrachloride. So first of all, I want you to know how can you get intoxicated by carbon tetrachloride. Carbon tetrachloride, it mostly intoxicates people who work in a dry clean. So you know this dry cleaning like shops? Yeah, so the substances they use, they contain carbon tetrachloride. If you get exposed to it, like a little bit of it, it's not a big of a deal, but people who work with it every day, they get it the worst. Actually, it's now illegal in the States to work with this, but it's still on the exams for some reason. So yeah, carbon tetrachloride is converted by the cytochrome P450 inside of your liver to carbon trichloride, a free radical. And that free radical can lead to fatty acid, and you must know that you get fatty acid and why you get it. They want you to know that the free radicals attack the apolipoprotein inside of your liver and destroy them. When they are destroyed, the liver is not able to get the fat outside of the liver and it will accumulate. When it accumulates, there will be fatty changes of the liver. And the area that will be damaged the most is the same area that contains the cytochrome B450. It's the central lobular necrosis. Okay, guys? Must know this. Okay, last thing. Metal storage diseases like hemochromatosis in case of iron and Wilson disease in case of copper. Okay, good. So let's go to the next page. We have types of calcification. By the way, I was telling you about Wilson and hemochromatosis. I have a note for you guys. Please keep it like near you. If they tell you about someone who had a liver transplantation and they ask you to compare Wilson with hemochromatosis, which one of these two diseases will have recurrent of the disease? Is it Wilson or hemochromatosis? Someone write in the chat. So someone get a transplant. If someone get a transplant, which one will reoccur? Is it hemochromatosis or Wilson? Yes, it's actually hemochromatosis, and the reason is that in hemochromatosis, if this is the intestine, the problem is overabsorption. So it's an absorptive problem. So even if you change the liver, you still have the problem. But in case of Wilson disease of the liver, the excretion of what? Of copper. Okay? So if you change the liver, you also change the ducts. So you have new ducts in your liver, so you will not get Wilson disease again. But in hemochromatosis, you will get it again because it's an absorptive dysfunction. Okay, anyway, types of calcification. Calcium deposit appear deeply basophilic. You can see the arrows. Remember in the previous class and the class before it when I kept drawing calcium to be blue and I told you because it's basophilic in histology? Yeah, here it is. So we have dystrophic calcification and metastatic calcification. So what is the difference between them? Dystrophic, it's when the calcium is normal inside of the body, but it waits for a diseased or a damaged tissue to go and stick into it. So the calcium deposition is mostly in an abnormal diseased tissue. For example, myositis ossificans, an example of metaplasia of connective tissue. It also has a lot of calcification on it. Why? Because of the trauma. Yeah? The fat necrosis in the chest has some calcification on the fat necrosis because of the trauma. So yeah, they try to, in case, for example, other causes that are interesting, pneumoma bodies, the same idea, trauma, schistosomiasis, trauma. So they write, in abnormal diseased tissue, it tends to be localized to the area of the injury, the diseased tissue. Like for example, you can get this calcific aortic stenosis. By the way, guys, if they give you a patient who has aortic stenosis, but he's only let's say he's only 45, please do not pick this. It's not dystrophic calcification. Why? Because dystrophic calcification, if you requires so many years. If you have someone with aortic stenosis and he's 45 or younger, or even you can say 50, 45 and younger, it will be a bicuspid aortic valve, complicated by aortic stenosis. But it's a bicuspid aortic valve. Please know this. They do ask it a lot. Okay, the next one is associated condition with this dystrophic calcification include the following. So the first association is with TB. Remember, please, that in case of TB, we had this constrictive pericarditis, we had this lung consolidation with a lot of calcium deposition here and there, which you were able to see it on the chest X-ray. So yeah, lung and pericardium and other granulomatous infection. Well, is there any other granulomatous infection? Yes, a lot of fungi can lead to granulomas, like histoplasmosis, for example. Also, liquefactive necrosis of chronic abscesses. So remember about when we spoke about liquefactive necrosis, we only occurred that it occurs in 3 places. The brain, that was 1. Abscesses, that was 2. And intrapancreatic, not peripancreatic, intrapancreatic. Okay. Also in fat necrosis, we said about fat necrosis in 2 examples: peripancreatic, not intrapancreatic, and the breast. Also in case of infarction, and in case of thrombi formation, and in case of schistosomiasis. Please know about the cancer associated with schistosomiasis. Schistosomiasis is associated with which type of cancer? They keep giving this question, is a trick question. You must choose bladder cancer, and you need to be specific about which type of cancer it is. It's not a transitional cell carcinoma, it's a squamous cell carcinoma, and the treatment is with the Brisenquintal. Did someone say anything? Okay, so congenital CMV and can lead to periventricular calcification and toxoplasmosis. How can I differentiate between CMV and toxoplasmosis? It's pretty easy, actually. It's not that bad. So in case of, just a second, CMV versus toxo. So in toxo, the calcification are intraparenchymal, okay? Intraparenchymal. While in case of CMV, they are periventricular. Which ventricle? Like the lateral ventricle inside of your brain. So these calcification are both intracranially, but in case of toxo, it's all over the place. In case of CMV, it's only around the ventricles. This is how you differentiate between the two. Also, rubella can have calcification. They are people with rubella is also associated with PDA, patent ductus arteriosus, which leads to continuous type of murmur. Also, pseudomoma bodies. Pseudomoma bodies are super important in histology, and we'll speak about them really deeply when we reach them. Actually, it will be next topic. Don't worry about it now. And the Crest syndrome. This is one of the forms of scleroderma that we are going to speak about in MSK. It includes people who have, the C stands for calcinosis, so you can understand why it's put in here in dystrophic calcification. C for calcinosis and also anticentromere. The R for Raynaud phenomena, the E for esophageal dysmotility, the S for sclerodactyly, and the T for telangiectasias. So lastly here we have atherosclerotic plaque can become calcified. So yeah, if you have atherosclerosis in your heart, the plaque itself, it can become calcified and creates a cap on it. So the etiologies of the dystrophic calcification, it can be secondary to injury or necrosis, okay? So it can be secondary to injury or necrosis. You need an initial trauma for it to happen. Keep in mind that the calcium level will be normal. Now we contrast that with metastatic calcification. It happens in normal tissue. It's why it's spread all over the body. It does not really care about which organ. The main idea of it, that it likes tissue that are highly acidic, guys. So calcium goes, not acidic, highly alkaline, with the tissue with high pH. So it goes, searches for tissue with high pH and go attached to them. So, for example, these tissues include the kidney. The kidney has high pH. Why? Do you remember where all of the bicarb is reabsorbed in your body? Exactly, it's your kidney. So it's highly alkaline. He goes there, have a lot of fun, and lead to metastatic calcification. Also in your lung. So why the lung? A lot of CO2, a lot of, sorry, I apologize. A lot of oxygen comes and a lot of excretion of CO2. The CO2 goes out. So when the CO2 goes out, you have more alkaline state. Okay, the last one, gastric mucosa. That might be a surprise for some of you. You'll be like, but gastric acid is the most acidic thing I know about. Yes, you are right, but here's the thing. The gastric, he did not say the gastric acid or the gastric lumen, he said the gastric mucosa. You guys, if you look at the mucosa of our stomach, something like this. So here we have a lot of acid, but our stomach is not stupid. It makes the internal mucosa really, really highly alkaline. Why it does this? Because she wants to neutralize the acid so it will not penetrate it, you know? So regardless of the fact that the lumen is ridiculously acidic with a pH of 2 to 3, the mucosa itself is quite alkaline, not to be destroyed by the acid. Okay, so yeah, that's the gastric mucosa. These tissue lose acid quickly. Okay, so there is increased pH that favors the calcium deposition. Great. There is one case you must know about. Nephrocalcinosis of the collecting duct may lead to nephrogenic DI and renal failure. How come? If you go to that section, the renal section, in the here it is. In the physiology, there is each portion of your tubules and what is its function. So if you look at the collecting tubule right here, exactly right here. Yeah, here it is. Collecting tubule, the principal cells. On the principal cells in the basolateral wall, this is the basolateral wall, this is the luminal wall. On the basolateral wall, you have the ADH receptor, the V2. So the ADH connects into it. So if there will be calcification of this area, the ADH will not be able to connect to its receptor. If he will not be able to connect to its receptor, there will not be creation of the aquaporin channels. If there will not be creation of the aquaporin channels, the patient will not be able to reabsorb water. So a lot of urine will go out. So you will have nephrogenic DI, secondary to what? Secondary to metastatic calcification leading to nephrocalcinosis of the collecting duct that leads to nephrogenic DI and renal failure. Okay, so what is the etiology of the metastatic calcification? Anything that leads to ridiculous amount of hypercalcemia. That include primary hyperparathyroidism. Okay, well, what can that be due to? Tumor, hyperplasia, anything. What about sarcoidosis? Well, sarcoidosis is actually interesting, and I would take a moment on it. So, making diseases. So we have a granuloma formation. Inside of the granuloma secretes something called 1-alpha hydroxylase. Okay, guys, you must know about this 1-alpha hydroxylase. This 1-alpha hydroxylase convert the 25 the 25 type of vitamin D to the 125 subtype of vitamin D. Which one is the active one? It's the 125. Which one is the storage one? It's the 25. So the granuloma help you make more active vitamin D. If that is true, that can lead, vitamin D can lead to more absorption from the intestine of the calcium. It also can increase the reabsorption of the calcium from the kidney and decrease of its clearance. All of these factors lead to hypercalcemia. Okay, so they write secondary to hypercalcemia, for example, due to hyperparathyroidism, sarcoidosis, and hypervitaminosis D. Or high calcium phosphate products level, such as in case of chronic kidney disease. Chronic kidney disease can lead to this. Okay, with secondary hyperparathyroidism, let's think about it. When someone has a chronic kidney disease, of course he will have more potassium level, but his calcium level is kind of tricky. It will be increased, but not because of the kidney disease, actually that can decrease the calcium. But when the parathyroid gland senses the increase in the potassium, she will be like, high potassium, I don't like it. So, sorry, not potassium, but high phosphorus, high phosphate. So the parathyroid gland will sense the high phosphate and she does not like it. So she will decide to increase a lot of parathyroid hormone. They will be working on kicking the phosphate out of the body, but in the same time, they will be increasing the calcium a lot inside of the body. If that is true, the patient will have hypercalcemia. Okay, what about the phosphate that the parathyroid hormone was working so hard into getting it out of the body. Well, sadly, he will not succeed. Why he will not succeed? Because in a case of chronic kidney disease, you have ridiculous amount of phosphate in your body that even with the kidney with the parathyroid hormone, you will not be able to get rid of all of it. Okay. Also, long-term dialysis can lead to metastatic calcification and a condition called calciphylaxis. I would like you just keep that one in mind. In 3 classes from now, we'll be speaking about it deeply. And the last one is multiple myeloma. Keep in mind that this one also can lead to lytic lesions. What about the serum calcium level in this condition? It will be usually abnormal. Okay, so the next topic, it will be regarding the lipofuscin. By the way, guys, when you look at the histological picture of lipofuscin, it exactly resembles hemochromatosis because both of them, like, I will show you guys, it looks exactly the same. And there is no way a medical student can differentiate between them. So lipofuscin look exactly like what it looks like hemochromatosis in histology. How does hemochromatosis look in histology? Of course not this. Let me show you here, hopefully. Come on. Lipofuscin. I cannot say it normally. Anyway, so it looks brownish, and when you see it, you have to differentiate it from hemochromatosis. There is an easy way and hard way to do so. So the easy way is just to look at, let's start with the hard way. The hard way is to be a pathologist and actually know the difference between these two. The easy way is to look at the age of the patient in the question. If the age of the patient is more than 70, it's lipofuscin for sure because it occurs in old people. But if the patient age is less than 50, it's hemochromatosis for sure because lipofuscin will not occur in a 50-year-old. So you take a look at it, you can see a lot of brownish pigment inside of the cells. These brownish pigment are the lipofuscin. So you see this, then I'm going to show you a picture of hemochromatosis. Histo. Try to differentiate between the two. Okay, yeah, so you can also see the brownish pigment here, and it looks kind of the same. So it's kind of useless to try to differentiate between them. So the easy way is just, you can see the brownish pigment here. So the easy way is just to look at the age. Okay, so lipofuscin is in all people. It's a yellow-brown pigment. It's due to wear and tear. So simply it's due to the age. It's associated with normal aging. It's composed of polymers of lipid and phospholipid complexed with a protein. So yeah, you must know that it's due to lipid peroxidation actually. It may be derived through lipid peroxidation. Do you remember what else led to lipid peroxidation? Free radicals, exactly. Of unsaturated lipids of the subcellular membrane. So basically it occurs in all people due to lipid peroxidation, and do not mistaking it with the hemochromatosis. It occurs in similar organ like hemochromatosis, but the main difference is the age. Autopsy deposits in the heart, colon, liver, kidney, eye, and other organs. And they want to trick you to choose hemochromatosis. Don't. Look at the age. Okay, so the last topic, I'm not sure we can finish this now. Okay. Okay, guys. So we finished today a total of 5 pages. It's not bad for today. You can see already we are moving a little bit quicker. By the time we will move quicker and quicker until we will be able to finish 10-15 pages per day. This will not be long from now. Okay guys, so that's it for today's session. I'm sorry today there will be no question, but there will be a task that you must do. And see you later. You decide guys when the next class is going to be. If you want, we can make it tomorrow. Okay guys, see you. Bye bye.